All right. Good afternoon, everyone. Welcome to the 4th annual Congressional Naloxone Training. My name is Libby Jones, and I am the Associate Vice President of Overdose Prevention at the Global Health Advocacy Incubator. On behalf of our team at GHAI, I want to thank the Addiction Treatment and Recovery Caucus, as well as the Bipartisan Mental Health and Substance Use Disorder Task Force for co-hosting today's event. I would also like to thank our special guest from Community Bridges. Make sure that you stop by and say hello on your way in and out. And I also want to thank the students that we have here today from Georgetown Medical School who are conducting the session for today. In the past year, the United States has seen a remarkable reversal in overdose trends. Where overdose deaths were once skyrocketing, they're now declining. And some states have seen a decline as much as 40%. There are many reasons for this, and we know, though, that naloxone distribution is a key part of the reason for us going in the right direction. This miracle medication, which we're all here today to learn all about, gives people a second chance at life, as well as a renewed chance of recovery. So September is National Recovery Month. This month we celebrate the 22 million Americans who consider themselves to be in recovery from substance use disorder. This month also gives us a chance to highlight all the paths to recovery. And that's one reason why I love this month so much. All the strategies that promote recovery, whether it's through widespread distribution of naloxone, better access to addiction treatment, or a strong network of peer recovery specialists, all remind us every day what we're fighting for. So again, I just want to thank everyone for joining us today. Before we hand it over to Georgetown Medical School, I am very honored to introduce a true champion of overdose prevention and recovery, Congresswoman Brittany Patterson.
Hi friends, I am so grateful that we're hosting this event to reduce stigma and bring awareness around the importance of access to naloxone and making sure that all of us are carrying naloxone, that we know somebody who is at risk of overdosing, that we are advocating for them to carry it themselves, for their loved ones to carry it. It's so critical. Before I go into more about why I care so much about this issue, I want to acknowledge that right before coming here, we saw the news that more political violence occurred in this country, and Charlie Kirk was shot, and it is a tragic situation. Moments later, I saw an update that there's an active school shooting in my district. And it's hard to believe the failed policies that have led this country to this place. And I'm glad that so many of us are here trying to fix things to save lives, and including here around supporting people who are struggling with addiction. My mom would not be alive today without naloxone. She, like so many people, was overprescribed opioids after she hurt her back when I was just 6 years old, and went through decades of hell. Her addiction ultimately led to heroin, mixed with fentanyl. The last year that my mom was struggling with addiction, she overdosed 20 times that year. The last day that she went to the hospital, 3 times in one day. And it is because of the naloxone that we had. It was because of the first responders who had access to naloxone. And this is a life-saving drug that needs to be widely available. We need to reduce those barriers. I personally administered naloxone to my mom. It is easy to use. It is, by the way, she just celebrated almost 8 years of recovery. And while we need more than naloxone, we need to make sure that people have access to treatment and recovery services, and that it was critical had all of those things every step of the way. She would have never had that chance to rebuild her life, to be there for, seeing my two sons being born and being there for our birthdays, all of the important moments in our lives. My mom would have never had a chance to be a part of that. So every day feels like I'm thankful that I still have my mom in my life, and happy to be a part of this priority and discussion to make sure that all of us are advocating for our loved ones to carry naloxone if they're at risk, to carry it with us when we're walking, if we see somebody who might be overdosing, who needs intervention. So just thank you all for hosting this event. It couldn't be more important. And with that, I get to introduce somebody who is leading on this issue, the chair of one of our bipartisan caucuses to address our substance use disorder policy recommendations to make sure that we continue to move on reducing overdose deaths here in the United States, and that is, will raise your hand.
Thank you, Brittany. And good afternoon, everyone. It is great to be here with all of you this afternoon. And we are celebrating the 4th annual Congressional Naloxone Training. We're grateful to the Hoyas for leading this invaluable session, to the Overdose Prevention Initiative for hosting us, to the Bipartisan Mental Health and Substance Use Disorder Task Force, which I co-chair, and I'm privileged to do that work with our other co-chair, Brittany Pedersen, along with the Addiction Treatment and Recovery Caucus for making this event possible year after year. So over the past decade, the United States has faced an opioid crisis of unprecedented scale, one made even worse by the COVID-19 pandemic. And while the challenge remains daunting, we have seen encouraging signs of progress. As Libby mentioned, last year the CDC reported the largest ever one-year decline in fatal overdoses recorded, down 26%. And the exact reasons are being studied, but experts point to several factors: wider availability and affordability of the life-saving opioid antagonists like Narcan, expanded treatments through telehealth, the elimination of the X waiver, and mandatory training for DEA registered prescribers. Together, these measures have helped prevent countless tragedies. I'm proud that the place we come to work every day is also stepping up. Recently, Narcan was installed in boxes alongside select AED and Stop the Bleed kits throughout the House office buildings, thanks to a joint effort by the Office of the Sergeant at Arms, the Architect of the Capitol, and the U.S. Capitol Police, and the Committee on House Administration. Easy access to Narcan is one of the simplest, most effective ways to save lives, as Brittany's mom's survival and recovery proves to all of us. But we can't take our foot off the gas. The CDC reported that in January of this year, fatal overdoses increased by roughly 1,400 compared to January 2024. That's a reminder that our progress is fragile and that we must keep investing in treatment and prevention. Yet at the very moment we need them most, the agencies leading the work, HHS, CDC, and NIH, are facing workforce reductions and budget constraints. Scaling back their capacity risks slowing our progress. I'm encouraged by the bipartisan commitment in this room to getting this right, and I'm confident that we can work together to advance policies that save lives, especially by maintaining strong support for proven harm reduction strategies like Narcan. We also have to remain vigilant against emerging threats like xylazine, an illicit drug that doesn't respond to naloxone, making education and awareness even more important. That's why today matters. This training is about more than just learning how to use Narcan. It's about empowering each of us to be ready to act. Every person in this room can play a role in preventing an overdose and saving a life. You may never know whose life you will save, but you'll know that you were prepared when it mattered. So thank you again for being here, for your commitment, and for being part of the solution. Now it is my great honor to pass the microphone to Congresswoman Judy Chu from California 28.
I'm Congressmember Judy Chu from California, and thank you for inviting me to join you today. I will never forget when my constituent, Ryan Hampton, came to see me. He was heartbroken. He himself had fought his way through addiction, achieved sobriety, and turned his struggle into advocacy by helping others in recovery. But he was heartbroken that day because he lost his friend Tyler, who died of a heroin overdose in a sober living home. And what made it so tragic was that Tyler's facility didn't even have Naloxone on hand, nor anybody trained on how to administer it. And of course, that could have saved his life. So Ryan brought his story to me, and we worked to pass a congressional bill to establish best practices and standards for sober living facilities, including Naloxone training. It did become law. Because of that, it means people like Tyler, who did everything right to rebuild their lives, can have a second chance. But there's so much more work to do to make sure that Naloxone is publicly accessible and affordable, especially in areas where overdoses are likely to occur. And it takes all of us, each in our communities, to educate ourselves and take action, which is why it is so great that we are all here today. That's why this training is so vital, where everyone will have the opportunity to learn the signs and symptoms of an opioid overdose, and also on how to use Naloxone, and how, therefore, we can give somebody a second chance at life. Today, there's such a growing awareness of this life-saving training that I find so encouraging. And in fact, recently, a community health center in my district in Southern California, ViaCare, launched its harm reduction program and made Naloxone available free of charge to all of their health centers, including the East Los Angeles College Student Health Center. By taking that proactive step, they made sure students and community members alike had the tools they needed in case of emergency. Their leadership is an important example of how access to Naloxone can be woven into everyday community health. By being trained in this, we are all standing up against stigma, standing with people in recovery, and helping to ensure that fewer families have to experience the heartbreak of losing a loved one to overdose. So thank you for committing your time, your energy, and your compassion to this cause. Together, we can save lives and support every person on their path to recovery. Thank you. Okay, so now I would like to turn the podium over to our Congress member from New York, Paul Tonko.
Well, thank you, Judy, and welcome everybody, and thank you to the wonderful team from Global Health Advocacy and Georgetown University for doing now a fourth, I believe, annual document training. Look, to have all the tools in the kit, policy, resource advocacy, training to save lives is what this ATR caucus is all about. And I see Brittany and Becca and Boreal in the front row, and Judy, countless numbers of individuals who, in a bipartisan coalition for over 20 years now, have worked to make the focus on addiction, treatment, and recovery a real outcome. Strong outcome. And so I thank everybody for participating, for hosting, and sharing your intellect and your abilities in a way that enables people to be empowered. You know, we're all in this battle together. I can say that, you know, we will continue to fight to make certain resources are there. From a health perspective, addiction as a disease needs to be conquered in that format. So research is valuable. Access dollars, affordability, all of that matters. So we will be in that fight. I can speak, I think, for our caucus that we're firmly in that fight and reject any notions of reducing our commitment as a nation to the fight against this illness that needs to be addressed with hope. It's the darkness of despair that has gripped many, and we want to be that hope and continue to work in that part. And so thank you for lending your expertise. It's so appreciated. And to my colleagues who are just loyal members of the caucus, thank you so much.
And now, Congressman Otto from Rhode Island.
Good afternoon, everyone. You know, we think about the manifestation of some of the challenges that we have with opioid addiction and with overdose, empty spots at the dinner table, parents missing milestones, names not read at graduation. And that's the cost of the opioid crisis paid for by far too many American families and communities. And so I'm very heartened to be in this room and see so many of you who have taken time out of your busy days to learn how to administer naloxone and maybe one day save a life. So I'm grateful to my colleagues in Congress who are here, and grateful to Georgetown and all of the work that you are doing today, which will make a difference. And while I hope no one ever needs to use these skills that everyone's acquiring today, it is good to know how. And that's why I'm proud to announce today that I introduced a new bill, the Bipartisan Having Overdose Protection Equipment, or HOPE Act, with my colleague from North Carolina, Addison McDowell. This bill would make it easier to stock naloxone in public places in my home state of Rhode Island and across the country. New England has been especially hit hard by the opioid crisis, but thankfully, we've seen the number of deaths drop over the last few years. Between 2022 and 2024, fatal opioid overdoses in Rhode Island declined by 36%. And that's largely because of increased access to harm reduction tools like naloxone. And I'm grateful to see those efforts in Rhode Island leading the way. In 2024 alone, naloxone kits were distributed across our state through innovative means like in vending machines. Those methods are working, and that's one of the big reasons that I introduced the HOPE Act. Just like putting AEDs in public spaces like schools, libraries, and parks have saved countless Americans from cardiac arrest, we can have a similar impact. This bill would make it easier for states to make naloxone available in public spaces, so bystanders, like everyone getting trained here today, can step up if they see someone experiencing an overdose and use naloxone to reverse it. Just like AEDs, overdose reversal kits send a clear message. This is a life-saving tool, and everyone should feel empowered to use it. And although we've come a long way in reducing overdose deaths, we still have a long way to go. That's why we're here. Naloxone is safe, it's effective, it's easy to use, it saves lives. It restores hope, and it needs to be everywhere. And I'm grateful to be doing this in a bipartisan way, working across the aisle to get this done. However, we see some efforts that are really working at cross purposes here, and especially as we are looking to expand naloxone access. It doesn't make sense to gut SAMHSA, the Substance Abuse and Mental Health Services Administration workforce. These are experts who are helping us in this mission to save lives. And certainly, seeing the Republicans on the House Appropriations Health Subcommittee cut $298 million from SAMHSA's budget does not move in that direction. So I'm hopeful that this legislation, that this convening, that these opportunities to highlight the importance of naloxone will get us to common ground where we are all in this together. Because ultimately, when we make naloxone available, stop overdoses, save lives, and restore hope in communities, we are moving our country stronger and bringing people together. And in this work, we can truly end this crisis once and for all. So thank you for everybody's effort. I'm hopeful that we'll be able to make an impact with this legislation. We do something that cuts across state lines, cuts across partisan divides, and really is about ensuring and restoring hope in so many Americans and their families. With that, I get to turn it over to my colleague, Ryan McKenzie.
Well, thank you to Representative Amo and the bipartisan group of colleagues who join me in this caucus and our fight to address addiction and provide necessary treatment and recovery options to Americans who are struggling with these challenges. And hearing from my colleagues, it was great to hear all the different legislation and opportunities that we are trying to advance here in Congress, because we know that substance abuse and addiction are multifaceted challenges. All different people get these addictions and challenges because of different things that they're facing in their lives. And one thing that I have worked on, is personal to me and my family, like so many other families across the country. Have had individuals who have had these challenges and ultimately losing a family member to substance abuse and addiction. When I see the challenges in our community, one of the things that I try to highlight and address is the prescription drugs that go out through the regular course of business when individuals have an injury or other things happen in their lives, and then all of a sudden that prescription turns into an addiction. And so in the Pennsylvania State House, I worked to provide new regulation and prescribing guidelines for injured workers who are being overprescribed in our workers' comp system. And here in Congress, just recently offered an amendment to this year's NDAA, the National Defense Authorization Act, to study our military health prescribing guidelines. So many of our military service members are facing those challenges. An injury occurs in the line of duty and in their professional capacity as a service member, but then they end up being addicted to those prescription drugs and then facing those challenges even long times after they depart their military service. So we want to continue to address all of these different challenges that I'm focused on and all of our other colleagues, because we want to make sure that we are doing everything we possibly can to avoid and reduce the number of these instances that are addressing and affecting so many Americans and their families all across our country. So with that, I just want to close by thanking all of you for being here today, by being part of this conversation, and also the solutions that we know are out there to address these challenges. So I want to wish you all the best as you go out from here and continue to work in Washington, D.C. and across the country, and look to us as resources, as your voices in Congress as we continue to battle this fight. Thank you again.
And now we get to started with the training. So I will hand it over to Michelle and Lillian from Georgetown Medical School.
Hello, thank you everyone for being here today. Again, I am Lillian and this is Michelle. We are second-year medical students at Georgetown University School of Medicine. We are here a part of Hoya DOPE, which is the Hoya Drug Overdose Prevention and Education club that we have here as an extension of our Hoya clinic at Georgetown. From us, we want to say thank you to all of you, to all of our representatives, to the caucus, for being here today, for participating in this training, not only through our work as healthcare providers, but also from a personal reason. My older brother passed away from an opioid overdose at the age of 20 years old. This is something that is extremely near and dear to my heart, and that was something that could have been prevented by the Naloxone administration. So I really want to again extend our thank you all for coming here today, for advocating for this issue, and for taking the time to learn about Naloxone and its life-saving effects. With that being said, we're going to go ahead and get started. We have some basic learning objectives that we're going to be going over today. I'm going to be starting with the first portion, and then Michelle will be taking over talking more about the laws associated with Naloxone. So what are opioids? We all know that they're a derivative of a poppy plant. There are different types that we have all heard of. So opiates are the direct derivatives of the poppy plant. So that would be morphine, codeine, things that we've all heard before. Then you can get into semi-synthetic opioids and fully synthetic opioids. Fentanyl being the main fully synthetic opioid that we are going to be talking about today. Fentanyl is one of the major contributors to the increase in overdose fatalities that we have been seeing in our country, and so that is the main topic of conversation.
more about opioids. They are drugs that bind to the opioid receptors in our brains, and the main reason that they have been introduced, especially in the healthcare setting, is for their pain relieving effects. Opioids, including fentanyl, have been found in illicit drug supply, and they can be administered in many different ways. This all being said, naloxone, no matter the type, whether it be an opioid, an opiate, a fully synthetic opioid, naloxone works on all of these and works to reverse the effects of their administration. So again, as I just previously said, the opioids impact multiple body systems, with that main one being that analgesia, that pain relief. And that is why we see it in the healthcare setting oftentimes in the case of those who are chronically ill, whether that be cancer patients or those suffering from chronic pain. They can also cause that euphoria feeling, and that is why that ultimately leads to that abuse of the opioids. We can also see sedation, slowed impaired movement, constipation, and itching. But the main one we are focusing on today is that respiratory depression. That respiratory depression is what ultimately leads that person into that opioid overdose state, and then can potentially cause that fatality. So with the naloxone administration, that is what we're looking to reverse. So I just want to talk about the similarity and the differences between different opioids. So we all have heard about heroin and fentanyl. They all are opioids, meaning that they all will be reversed by naloxone administration. However, the potency is different between them. So we can see in this image the fatal dose amount of heroin versus fentanyl, with fentanyl being 10 to 50 times stronger than heroin. Fentanyl is really the key player in this opioid overdose epidemic that we are seeing, because it is not only being used, it's also being placed into other illicit drug supply, as is a cheaper option oftentimes. So that is something that we really want to talk about, is that a lot of individuals do not know that they may be consuming that fentanyl, which is more than they had originally, or is more potent than what they may have originally used in the past. That ultimately leads to that opioid overdose. So I want to thank everyone also for talking about the amazing, inspiring statistics that we are seeing in the reduction of opioid overdose fatalities. We're going to be talking about opioid overdose fatalities specifically to DC. This information and these slides are provided to us by the DC Department of Behavioral Health. So our statistics are a bit over. We are very happy to see that reduction in that fatality, but what was so eloquently said previously is that this progress is very fragile, and we are very capable of reversing back, so we want to spread this information and continue with this progress. So this is just from 2018 to 2023. We can see that non-fatal opioid overdoses have been steadily consistent with the different lines representing different years. However, we can see a marked increase in opioid overdose fatalities. We see that huge increase, about 46% between 2019 and 2020, which we cannot definitively say the reason for that market increase, but we can all allude it to the COVID-19 pandemic, with social services and resources not being as available. Line is representing fentanyl, and you can see that that is the largest increase, starting again from about 2019. Huge market increase into the introduction of why someone is overdosing and ultimately passing away from opioids. So again, that is something that we really want to talk about and focus on today. We can see that in DC, that fatal opioid overdoses disproportionately affect Black DC residents. We can also see that the average age is about, which is on the slide, is about 56 years old. So oftentimes in the media that may be portrayed as a younger individual. However, we want to note that in the district, it does seem to be an older population. We can also see fatal opioid overdoses by gender, seeing that markedly throughout since 2016, it's been primarily men. Before I get into this most important slide, I would say, of the epidemiology, I do want to make a note. We are reporting the trends that we do see in DC. It is very similar to what we are seeing in other urban communities. However, opioid overdoses do not discriminate. There is not a classic presentation of someone who will be presenting with an opioid overdose. We do not want to get that into your mind. It can be anywhere, any state of life, any community center that you're at, any place. So we do not want you to leave this presentation with what you might perceive as someone who could potentially be overdosing in mind, because it affects everyone. So I really want to emphasize that. But we want to emphasize that we can see that it's disproportionately affecting Black DC residents. This slide is fatal opioid overdoses by ward of residents. So as we know, in DC, we have 8 wards. We can see wards 5, 7, and 8 have the highest rates of opioid overdoses, and we know that those wards have been historically oppressed and underserved in DC. So we really want to make a note. For these statistics, I also want to emphasize that this means ward of residents is the ward of residents of that individual's driver's license. So it doesn't mean where the overdose fatality occurred. It is that could occur in any ward. For example, someone from Ward 8 could have overdosed in Ward 1, but their license is registered in Ward 8 with their address. So that is how it's recorded. So their numbers would go in Ward 8. So we can see individuals from those areas are disproportionately affected. So we can see those trends that we talked about, and we know the key factors that play, the social determinants of health, healthcare disparities, historic, institutionalized, and systemic racism that we see built into our institutions. With that being said, this is funny, but with that being said, Narcan is a fantastic solution. It is helping. We're seeing the effects. But as legislators, we want to reach out to you and emphasize that it is a Band-Aid for the current disproportionate problem that we are seeing, especially in DC. And we urge legislation to be done to target these institutionalized core root causes of opioid overdose and abuse. So with that being said, we're going to get into the meat of our presentation of how to recognize and respond to an opioid overdose. So there's a lot of myths that have been heard and commonly accepted when we do these trainings in other areas of the district. These are often things that people come into. So these are a few things that I want to emphasize not to do that is technically has been perceived as common practice, which is actually just tends to be a myth. So first off, we do not want to put that individual in a bath or shower or at the same time put any ice in their clothing or anything like that. Oftentimes people think that this will wake up that individual and prompt them to respond. However, that is not the case. They are in a state of respiratory depression. So that means that they are not breathing at the rate that their body needs that oxygen. So we do not want to put them into a bath or a shower because there is worry and potential for them to drown because they are not breathing at the same rate, and they may also then become unconscious and then go underneath that water. In terms of not inducing vomiting or giving them something to eat or drink, opioids bind to receptors in your brain. So as soon as they reach that bloodstream, they're going straight to your brain, and there's nothing you can do besides administering naloxone to knock those opioid receptors off, or knock the opioids off those opioid receptors in your brain. So inducing vomiting or giving the individual something to eat is not going to help in that situation. With that being said, again, they're in a state of respiratory depression. While not necessarily having any necessary cardiovascular effects, for example, it doesn't necessarily slow down their heart rate, we do not want to put them in a situation that is going to further slow down their heart rate or abnormally speed it up by doing anything that could stimulate them, like putting ice into their clothing or things like that. Again, shaking them, slapping them, causing them any harm, is just going to do that, cause them harm. It is not going to knock those opioids off the opioid receptors in your brain. So why Narcan? Very quickly, there are other types of naloxone. Narcan is the name brand. The other types of naloxone require intramuscular injection, so we recommend Narcan just because it is that aerosol spray. It can be, after administration, it can be put into a basic garbage can. It does not need to be in a biohazard container. So that's why we say to use Narcan when possible when administering naloxone. So we're going to get into how to use the naloxone. So this may be arguably the most important slide of this entire presentation. We have about 5 steps that we like to say in terms of responding to an opioid overdose. If you take anything away from this presentation, I want you to know steps 1, 2, and 3. 4 and 5 are if needed in certain situations. We will go over them. We want to assess for responsiveness, call 911, administer naloxone, perform rescue breathing if needed, and also put them in that recovery position if needed. Time is of the essence in terms of responding to an opioid overdose. Again, we're talking about that respiratory depression that is going on. That means that individual is not receiving enough oxygen to their brain, which could lead to permanent brain damage. So we want to get rid of that respiratory depression as soon as possible by administering that naloxone. So oftentimes, steps 1, 2, and 3 are happening all together in a matter of seconds or in different order. That is fine. We just want to make sure that you do all of them. So there's been a lot of questions because we know that opioids affect many different body systems. So there is a difference between someone who is just under the influence of an opioid versus someone who is actually experiencing an opioid overdose. So again, not all signs of opioid use are necessarily indicative of an opioid overdose. The main signs that we want to look for you to look for in terms of when to respond and when to call to action is going to be if the individual won't wake up. So again, that's an assess for responsiveness, which we will go into further detail about. If you hear a difficulty breathing, it is almost like a gurgling, snoring sound. It is very distinctive. And also, if their fingernails, their lips, or their nose, or anything of that sort is turning a purple, gray, or just discolored portion, that means it's indicative that they are not receiving enough oxygen to their brain, and so that is when we would like to intervene. However, I would like to emphasize, if you are ever finding yourself in a situation where you are not sure if you should administer the naloxone, it is safe to do so. It does not cause any side effects in those who are not actually using an opioid or experiencing an opioid overdose, and it is safe in pregnancy. So when in doubt, please do administer it. It will not cause any side effects to the individual and harm them in any way. Again, if they are not responsive, that means they're not overdosing on opioids. So that is why we also still call 911, because that means there is another health crisis going on that EMS will be able to help them with. So that's also why we emphasize that. So again, it's really that they will not wake up, won't respond to your acts of responsiveness. They have that discoloration in their fingernails or their lips, and they have that really difficult breathing sound. Again, this is not all inclusive. It means they could have one symptom and not the others and still experiencing an opioid overdose. So again, step 1, safely assessing for an opioid overdose. So this is not necessarily in the slides, but the number one rule in terms of responding to a medical emergency is to make sure that you are safe in doing so. So make sure when you approach an environment where you may be doing this, that you are going to be safe and out of harm's way as well. We do not need 2 individuals that will need medical care in that situation. Next, we're going to assess verbally. If you know their name, you can call that out. If not, you can say, I'm going to Narcan you, or call 911 if you do not respond. We will talk about this in later slides. However, Narcan does put an individual who is using an opioid into instant withdrawal. So a lot of people do know what Narcan is because it puts them into that really uncomfortable feeling. So saying I'm going to Narcan you may prompt someone to wake up and respond because they do not want to go into that immediate withdrawal. So we're also going to assess physically. So again, we do not want to punch them, we do not want to hit them, we do not want to do anything like that. However, if we all can hold up one of our hands and put it in a fist and take your knuckles, you're going to find that little clavicular notch right here in between, and you're going to roll down just a little bit. And you're going to take your knuckles and just gently rub on top of your sternum, gently. You can feel that that is already uncomfortable just with that light rub. If you do that with some more force, that will definitely prompt someone to wake up. It is an uncomfortable feeling, however, it will not cause them any physical harm. So that is how we recommend that you physically assess for responsiveness, because that feeling will wake someone up. And thank you to Michelle for helping out so much with the presentation. Again, this should be very quick. This is time is of the essence. It should be about 5 to 10 seconds total. Next step is call 911. Again, these can be interchangeable. If you are with someone, you point at them and you say, Michelle, call 911. Get them onto it. Make sure that there is EMS on the way. Again, we may not know if there is an actual opioid overdose going on or another medical emergency, but we want to get that person help regardless. Also, with that being said, Michelle will talk on this later in the slides. Naloxone lasts in the body for about 30 to 90 minutes, while opioids last in the body for up to 6 hours. So it is possible for someone to receive naloxone, have them wake back up and respond, but then that naloxone will degrade in their body. That opioid will still be there, will will bind back to that opioid receptor and could put them back into an opioid overdose. So that's why we want to make sure that they are receiving medical care. However, I will say, if you are in a situation and you have called 911, the person does have the right to deny medical care. That is their right, that is their privilege. If you are able to stay with that individual, we recommend that. However, that may not always be the case, so we just encourage them to receive medical attention. A lot of times people do not feel comfortable saying that the individual they are with is experiencing an opioid overdose or anything drug related in terms of being in trouble. So here are a few phrases that you can say. What we really want to emphasize is when you call 911, you would emphasize that that person is not responsive and they are not breathing. That will get the medical team there quickly and have somewhat of an idea of what is going on and how they can help out that individual. So those are kind of the two main things that you really want to get across. Okay, now we're going to administer that naloxone. Again, this is all interchangeable. So we do not have any Narcan, or we do have provided by a wonderful community-based organization in the back. However, I do have this little tester here today. So you're going to peel open the package, and this is perfect, thank you. Tilt the person's head back. So this seems to be similar to that of like an allergy medication, like a nasal spray that we've all seen. We do not want to do a primer spray. So that is oftentimes what I do personally when I put in my own allergy medication. However, if you do that, that will result in the medication being administered into the air. So what you want to do is you tilt that person's head back. You're going to take the naloxone and put it into their nostril and just click the plunger and it will spray into their nose. You're going to wait about 2 to 3 minutes for responsiveness. If they are not responding, you want to administer that second dose that does come into the box of Narcan. We do recommend administering it into the second nostril, so not the one you originally used. However, we do understand this is a very chaotic situation and you may not remember what nostril you administered it in, so it's okay if you administer it into the same one. Again, that is just one pump, one spray into one nostril. It's not 1, 2, it's just one up. If you remember to tilt their head back, that would be great because the top of the mucosal surface is vascularized and we want to get that naloxone into the bloodstream as soon as possible to go to the brain and knock off the opioids on the opioid receptors. Again, this is going to be step 4. So again, those 3 steps, really emphasizing it. We're going to assess responsiveness and safety, call 911, administer naloxone. Perform rescue breathing is only necessary if needed. So that's after you administer the naloxone. The person's breath still seems shallow. If you are comfortable or if you have one of these CPR face shields, you can place it over the individual's mouth and perform the rescue breathing. We do want to emphasize not to perform CPR because again, this is a respiratory depression situation. The individual's heart is still beating normally, and with CPR, if you are doing it correctly, you may ultimately break the individual's ribs, and that will cause them further harm, so we do not want to perform CPR in this situation. However, if you come up to someone and you are not sure the medical emergency that they may be receiving, if you do begin to perform CPR after naloxone administration, you are protected by law, you are acting in good faith. So we do really want to emphasize acting in good faith. You are protected because you had good intent of helping out that individual in an emergency. However, we do want to emphasize if you do know it is an opioid overdose, we do not want to perform CPR. The recovery position is for someone after administration of naloxone. They're awake, but they're not able to sit up on their own. Naloxone, as one of its side effects, can cause nausea and vomiting, and we don't want that individual to choke on their own vomit. So we want to put them by laying them on their side, taking their opposite knee and placing it over them, almost like a kickstand, and taking that same side hand, that knee that you bent, and placing it underneath their head. This position will allow the individual to stay and not roll over onto their back in the event of vomiting, and then they will not be able to choke on that. So that's a position. Again, these are 2 situations that are as needed, and only if you feel comfortable. The main thing we want to emphasize is administering that naloxone. So a lot of people don't like to get involved into these situations because they're also worried about touching fentanyl, and I've heard things into the news. The main thing I want to emphasize is staying calm. Oftentimes, people touch fentanyl and then receive panic attack symptoms because they are nervous about experiencing an overdose themselves and then mistake those symptoms as an overdose. So we immediately want you to stay calm. We want you to wash your hands thoroughly and avoid touching your face. It is a common misconception that you can touch fentanyl and it can get through your skin and cause an overdose. That is not true. The only way it can cause an overdose is if it gets into those mucosal surfaces. So whether that be your mouth, your nose, your eyes, your ears, things that are highly vascularized. So that's why we say if you touch it accidentally, you will be fine. Just do not touch your face or any of those surfaces because that is how it could potentially get into the bloodstream, and those are the news stories that we have seen. So again, really washing your hands. Again, you cannot inhale fentanyl. It cannot be aerolized if you're in a situation where you're in a room and it may be present. Again, you cannot inhale it and then receive an opioid overdose, as well as there's been no danger for first responders. Again, it's not touching it, it's having that onto that mucosal surface, so we really just want you to wash your hands and avoid touching your face. So do not let this prevent you from getting involved. So we don't have I think the plunger is being passed around, so again, I really want to emphasize those 3 steps: assessing responsiveness, calling 911, and then administering that naloxone, again, into one nostril only, and do not do that primer spray.
All right, we're going to move on into Lily, how to do it, so I have to do it too. We're going to move into what happens after you administer naloxone. I love the schematic if you guys get a chance to see it. We have our opioid receptors that the opioid is binding to when a person uses. And then you administer naloxone. What it will do is knock the opioid off the receptor and bind with higher affinity, preventing any opioids from binding to that receptor as long as naloxone is in the body. However, as Lillian mentioned earlier, opioids can be in the body from anywhere from 1.5 to 3 hours, depending on the type of opioid and the route of administration. Naloxone starts to break down after 30 to 90 minutes, however. So it's possible that after 30 to 90 minutes, naloxone starts to break down. It leaves, there's that beautiful schematic, it leaves that opioid receptor and then it opens it up so that opioids can bind once again, even if the person has not used more opioids. Because of that, we would encourage for the person to not use more opioids, to introduce more into their system. And if they were to fall back into an overdose, you would just administer more naloxone. It will work just as effectively as the first time you administered it. You'll want to encourage them, like I said, not to use again and to seek medical attention so that they are under supervision of someone who has additional naloxone. If they refuse healthcare, that is absolutely their right, but you may be encouraged to stay with them for up to 3 hours, or if you cannot, encourage them to be under supervision of a friend or someone who can do so. I'm going to go over some of the side effects of using naloxone. As Lillian mentioned, they send a person into withdrawal symptoms. So that would be chills, dizziness, fever, headache. All right, nausea, rapid heartbeat, sweating. So these are obviously uncomfortable side effects. However, I want to emphasize that they are temporary. There is no harmful side effects. If no opioids are taken, I could use naloxone right now and I wouldn't even feel it because there are no opioids in my system. There's nothing that is knocking off a receptor, and so I will not have any side effects. So if you're in doubt, always use the naloxone. There's no harmful side effects. It's safe to administer in pregnancy, and it's safer to experience these side effects than to experience a prolonged overdose. Like I mentioned, those side effects are uncomfortable. The person will likely wake up not remembering their overdose, and they'll probably be scared and feeling ill. It's a really stressful situation to be involved in for both the person who's overdosing and you as the responder. So we want to acknowledge that, and we want you to acknowledge that there are resources available and that you may have feelings about the situation. However, you are always doing the right thing by saving a life. Never feel bad about that. All right, we're going to go over into how to store your naloxone. Naloxone should be stored at room temperature. Rule of thumb, wherever you can go, naloxone can go. Don't freeze it. Try not to leave it in your car. Keep Narcan in its box. It's back in the back of the room. It comes in a white box. It protects it from sunlight. You'll want to keep it in there until it's ready for use. Once you do use it, like we said, there is nothing sharp in there. It can just go into the trash can. You'll want to try to replace naloxone before its expiration date. However, there are studies that have been shown that expired naloxone still works years and years after its expiration date. So it's better to use expired naloxone than no naloxone, but try and replace it if you can. We're going to wrap up this conversation by talking about laws and what your personal protections are regarding carrying and administering naloxone and being at the scene of an overdose. I want to emphasize that an overdose is a healthcare emergency and it should be treated as a healthcare emergency. There are laws in DC that recognize this, and I know some of you may be from different states, so recognize that your states may have some nuances in the laws. We're going to go over DC specific laws. So the laws are the Good Samaritan Law and the Opioid Overdose Law. Basic summative, what these laws say is that no one will be charged for drug possession if drugs are found at the scene when responding to a healthcare emergency for an overdose. So that includes protections for providing alcohol to minors, any drugs found at the scenes. This extends to both the person overdosing as well as any bystanders. However, this does not provide any protection against other crimes that may be occurring on the scene. Also, you should be aware that drug paraphernalia, so needles, pipes, syringes, anything having to do with administering drugs is decriminalized in DC, even beyond just the scene of an overdose. It is legal for a layperson to carry and administer naloxone to someone they believe is overdosing, even if they have not been trained on how to use it. So you will not get in trouble for having naloxone on you. As well as the Good Samaritan Law, you will not be held civilly or criminally responsible as long as you're acting in good faith, even if the person gets injured or does not survive the overdose. This is the Good Samaritan Law, so it applies to most medical situations beyond overdoses. And then this is just for community-based organizations. So laypersons can distribute naloxone in the community as long as they've met 3 conditions. They have taken the district's official naloxone training. That's checked for you guys. This is what this is. Your organization has a standing order signed by a physician, which means that you can just give out naloxone. Physicians have approved it. And then you give them a brief training on how to use naloxone. So just 2 to 3 minutes summative of what we're doing today. All right, there are different places that you can get naloxone. Every pharmacy should carry naloxone. Usually physicians, when they prescribe opioids, they'll also prescribe Narcan along with it. So pharmacies know what it is, they should carry it. There are 30 partner pharmacies that are no cost, no identification, and no prescription. So you can go onto the Department of Behavioral Health's website if you want to find out what those are. And then there are also partner organizations like Syringe Exchange Services and outreach programs that carry it as well. This is a good resource for you guys to just be aware of in case anyone asks. There is a text that you can send and someone will deliver Narcan to you. So this is great if someone does not have transportation. You have to be in DC to use this service. You don't have to be from DC, you just have to be located in DC when they make the delivery. Now the next 2 slides are just about becoming a naloxone distribution partner. If this is something you're interested in, we are happy to give you more information on that, as well as what to say when distributing naloxone. All right guys, that wraps up our training. We want to give you a big thank you for your attention, your willingness to come and listen to us today, and we hope you leave empowered today, knowing that you just learned how to possibly save a life one day. This QR code right here, if you scan it, you will complete a post-test. You have to get an 8 out of 10, and then you will become certified, and you will receive a certificate in your inbox. We are happy to take any questions, and we thank you again.
So can I see the last slide that you went through? Yeah, thank you.
No problem. And then for those of you who are taking the quiz, we are located currently in Ward 6. Again, if you have any questions, then you will, like Michelle said, receive that certificate from the DC Department of Health, which then also formally makes you no longer a layperson. You are now certified and trained in naloxone administration. Again, we really thank you. That was a lot of information very quickly. If anyone has any questions, we're happy to take them now, or please come up to us afterwards, and we'll be more than happy to answer them for you.
Thank you.